All right, good evening. Chapter 6, the therapeutic approach to patient with life-threatening illness. So right there is the term we want to use. We don't want to say terminally ill, hospice patient anymore. We're just going to say life-threatening. So anything that's life-threatening is going to cut off your life fairly short, right? Or shorter than natural. So that's the term try to use from this point on, life-threatening. Cultural perspective. So think of different religious backgrounds, different beliefs on the body, the soul, spirituality. So some cultures believe that you just change to a different form of life. Others believe you get reincarnated. Other religions require the body stay intact and in whole. So you can't do any major alteration. So make sure you're aware and sensitive to those needs. Urgency of decisions. So if it's life-threatening, really short life expectancy, then we have to make these decisions quickly. And one of the main things is health decisions and financial decisions. And those can cause a lot of burden on the patient and their family. Patient have the right to choose or refuse treatment. That's all in the informed consent. And they can put that in their advance directive or their power of attorney. Have you guys heard of those legal terms? So it's kind of you're giving the rights to make decisions on your behalf to somebody else. Kind of have a proxy, somebody that stands in your place. While you can't make those decisions, you might be unconscious, etc. What does palliative mean? What's ambulatory? What's palliative? Not when they're dying. Palliative is not really treating the disease, but treating the symptoms of the disease, like pain, vomiting. That way, the patient is more comfortable, right? Yeah, even though we know that it's life-threatening, short duration, short life expectancy, we still want a high quality of care. So that's all the treatment that doesn't really treat the condition, but help you deal with the pain, symptoms, etc. So that might include, counseling for their psychological needs. Some patients will voluntarily stop eating and drinking. So in certain cultures, they do have assisted suicide. So in India, they'll give their elderly coconut milk, high doses of potassium, causes kidney failure. And then they choose to prevent their elderly family member from feeling all the pain of life-threatening conditions. So some cultures accepted, others not so much. There's a video on it. We can watch that if you guys like. Total sedation. So here we're going to increase the pain medication. And what happens when we keep on increasing pain meds? Eventually it'll paralyze their muscles, their diaphragm, they stop breathing, and that what eventually will cause death. So we know these things, and a lot of times for C2s, they're for hospice patient. As long as you write that on the prescription, you can actually get refills. You can continue to get refills because we know it's for life-threatening conditions. A few states allow assisted suicide. Doctors can prescribe you a high dose of barbiturates, and people can choose to take their own lives at home with their family. So they'll be with their family, they're comfortable, they're all together, and then they just congest that high dose of barbiturates That's pretty much like a high sedative, stops their breathing, they die in peace, with no pain. So, you guys remember Dr. Jack Kevorkian? You guys remember him back like 30 years ago, 20, 30 years ago in the 90s? He was one of the first assisted suicide doctors, and it was a big controversy. And another one was Mary Schiavo case. You guys remember that case about 15 years ago? She was in a vegetative state. Her family wanted to continue her in that vegetative state, but her husband wanted to pretty much take her off life support. Right? There was a big debate if she was still alive or not alive, if there was brain function or not brain function. Can we give her water or do we not give her water? So there was a big debate. And with that story, spoiler alert, they were ending nutrition to her. They're going to stop giving her water and tube feeding her. And then, of course, she passed. So was there a power of attorney? Was there a predetermined medical directive in that case? Or was it the husband's sole decision at that point versus the family? So the scenario at the beginning of the chapter mentions that a patient comes in to receive news of a life-threatening condition. So how would you alter your approach when that message is delivered? What's the patient's emotional state going to be? Yeah. They're not going to be clear-headed, and if you try to give them directions at that point, it's not going to go through. So you're going to meet them the same, receive them the same, but after you give them the news, you're not going to go ahead and schedule your next appointment. You're not going to do the normal exit routine that you do because they'll be too distraught to remember anything. All you're going to do is make sure that is there anybody you want them to contact or anybody to pick them up. That way they can get home okay. So it's later on you'll set up the next appointment. Alternative methods of treatment. So usually once all conventional Western methods fail, that's when a lot of patients will then try alternative treatments. They'll go to different countries where other treatments are available. Sometimes they're scams, but sometimes they do work. So if it works, it's not a scam. I don't know why it works sometimes, but some of those weird methods do work. Pain management during life-threatening illness. As mentioned, as long as it's written on the prescription, when it's filled, this is for a hospice patient or life-threatening patient, then it's pretty much a standing order. You can actually refill C2s, C3s for the pain management. Because it would be a pain in the butt to go back to the doctor every single time you need to fill that prescription. Remember, we're going to keep on increasing the narcotic dose so they're more comfortable, and ultimately that will cause death. Legal protection. So these are documented. Make sure you have the updated copy in the patient's chart. So if there's a new one, make sure you get them in. So durable power of attorney or a healthcare directive, healthcare proxy. So this is, you already made the decisions ahead of time. What to do if you go in a coma, what to do if your kidneys fail, or you can designate somebody, usually your spouse or a family member, to make the choices for you in that time. Financial issues. Many patients don't want to leave their families with huge bills. So that might come into play with the decisions they make. We know that treatment for, say, cancer can be very expensive, hundreds of thousands of dollars every year. And then surgery on top of that, hospital stay can be very expensive. So if the insurance company doesn't cover it, then make sure they have arrangement for that. Something you don't want to talk about, but you have to bring it up. Can cause a lot of distress in the family as well. Do you guys recall the classical stages of dying? 5 classical stages: denial, anger, bargaining. So we'll talk a little bit about those stages as well. So psychological suffering usually leads to physical symptoms, right? So if someone's depressed, sad, a lot of times what happened to their weight? Either they lose weight because they stop eating, or they gain weight because that pleasure from eating takes place of their emotional needs, right? Their psychological needs. What other physical symptoms might happen? Too much? Yeah, too much sleep or no sleep at all, right? So a lot of changes can happen. Goals, make sure they're able to set small goals. We'll talk about a few conditions, HIV and cancer patients. A lot of times we don't want to refer to patients of having AIDS because that's kind of negative. When you have HIV, you're contracted with the virus. When your T cell count falls below 200, normal is about 1,000. But once it falls below 200, that's when you have AIDS. That's when you have the syndrome. And that's when you're more susceptible. So we like to say patients with HIV or advanced HIV instead of saying AIDS. I guess that's another label we want to avoid. New HIV cases are generally the young. Right, so it's kind of scary. I remember growing up in the 90s, there's a lot of HIV awareness. And in the culture as well, there's a lot of things promoting safe sex, safe practices, not sharing needles to prevent the spread of HIV. Nowadays, I think we need that re-awareness for HIV, especially in our culture today. Social media makes it a lot easier. So the 90s, I think they blame it was the gay culture spreading HIV. Nowadays, it's the hookup culture that we have, right? Everyone has social media, Tinder. They can explore their sexuality easily, and now they're not as aware of the consequences. All right, so as mentioned, full-blown AIDS, the syndrome, T-cell count less than 200. And this is when your body can no longer fight off things that you normally would survive, like the flu. Now the flu is deadly. Fungal infection. Now you can't fight off skin conditions. Tumors, right? Your body normally will attack tumors, destroy them. But now tumors are turning into cancers because your body's immune system can't identify them and fight them off anymore. Wasting. You guys know what wasting is? Cancer patients sometimes will have wasting condition. That's when you lose all your muscle mass. So even if you try to eat, you can't absorb the nutrition. So you literally turn into skin and bones. So the only one of the few conditions where you're allowed to use human growth hormone is with wasting condition in advanced HIV and cancer, of course, to maintain healthy body weight, and for dwarfism to achieve a natural stature. So if you use human growth hormone for anything else, it's not approved. Cancer. It used to be a diagnosis of cancer was pretty much certain death. Nowadays, we're a lot better at cancer treatment. We used to give people chemotherapy week after week after week after week. We did not let their body recover, and we ended up killing many of our early cancer patients than helping them. Nowadays, we're smarter. We give a round of chemo. We give the patient about a month to recover, and then we give them another round of chemo. So we give plenty of time for the body to recover. So the treatment of cancer sometimes is worse than the cancer itself. And that's because most of the treatment options, surgery, radiation, chemotherapy, damages healthy cells. But the strategy is it also damages the cancer cells, but the healthy cells can recover better than cancer cells. So with the repeated regimens of chemo, the tumor should shrink until it disappears. So once it disappears, then that's remission. So some self-esteem things you want to watch out for is hair loss, right? Their appearance will change. So a lot of times, train the female patients how to do a head wrap, wear scarves, how to pick out wigs, things like that. That's help keep their esteem needs. So the reason hair falls out is because chemo and radiation therapy prevents cell division, and skin cells divide very quickly, and hair is just modified skin cells. So since the hair can't divide anymore, skin can't divide anymore, you lose your hair. And also your GI tract. Some of those cells in your GI tract only live for 3 days. So now they're not being replaced quickly. So you have a lot of GI problems as well. End-stage renal disease. Well, the good thing is it's a painless death. So you can go in your sleep and it's not painful at all. So once your kidneys fall below 10% kidney function, now you have what's called end-stage renal failure. Right? So the only way the toxins in your body can be filtered out is through hemodialysis. So have you guys seen the commercials in the news? No on Prop, whatchamacallit? I don't vote, so. No on Prop, what is it, 8? Because it's supposedly shutting funding to these dialysis clinics. And how often do patients with dialysis need to go in? Yeah, 2, sometimes 3 times a week. And it's true, there's only limited seats, limited machines, limited clinic time. And if they're cutting funding, dialysis is life support for these patients. So what is the alternative to hemodialysis? Your kidneys aren't working, we can't filter your blood, then we need to give you a transplant. So are there enough people willing to donate? No. So sometimes what do they have to do? Waiting list, black market, go to different. So in other countries, they can sell their organs. Technically, it's not legal, but it's a gray market. So people do sell their organs. And then in the United States, you can't sell body parts. So technically, if you have 2 good kidneys, you can't sell one of them. You can only give one away. But most of the time, family members are the likely match. But if a family member is not a likely tissue blood match, then you have to go outside the family, and it's very rare that someone would want to donate a kidney. So a lot of time they'll have a domino kidney transplant where my mom will donate a kidney if you donate a kidney to me. So sometimes they'll have like multiple surgeries, like 15, 20 different surgeries, so no one can back out of giving an organ. The other type of dialysis that you can use is peritoneal dialysis. So here in your peritoneal, the membrane of your abdomen, they'll put in an extra super salty solution. There's a catheter site, super salty. And if it's salty, it's going to suck in water and toxin. So now your peritoneal membrane is doing the filtering of the toxins for you. You rinse it out, it turns all Coca-Cola dark yellow, and then you put in fresh salty water. So that will keep you alive, but you're gonna need a kidney transplant. So time's ticking for these patients who's on that waiting list. Are you guys on the donor? Are you guys donors on your driver's license? No, yes, maybe. So my question to you, okay, think about it. You yourself, you need a kidney, right? Your family members don't match. Your friends don't match. We had a school drive. We tested everyone in the school. All of our 10 campuses, no one matched. Sorry, we tried, right? But there is a kidney. It matches you. But it's hepatitis kidney. Patient had hepatitis. Do you want that kidney? You're going to die without a kidney, but this kidney has hepatitis. Are you going to take it? Yeah, now they're reconsidering rejecting those kidneys because we can treat hepatitis. There's a good chance you can live a nice life, a few 20, 15, 30, I don't know how many years, but would you take that hepatitis kidney? I would. Yeah. I'd take my chances. Hepatitis medication, not too bad. How about if it was an HIV kidney? Patient with HIV matches you, but they just happen to have HIV. Now, would you take the kidney? Yeah, but treatment. Look at Magic Johnson. He's living a nice, long life. He has HIV. So, reconsider. We're reconsidering non-optimal organ donation. So, think about it. Might save your life. All right. Stages of grief. So, the Kubler-Ross stages. So, denial, anger, bargaining, depression, and then acceptance. So patients may go through all of these stages or just a few of them. Sometimes they experience these stages simultaneously. So not all go through them. So we'll go over each of them. So if you know their needs during each stage, then you're better to deliver care. The other thing is tier. So to accept the reality of the loss, experience the pain, adjust to what's lost, and then reinvest in the new reality. So this is the biggest here is to experience the pain. A lot of patients are still in that denial and they're still trying to run away. And lastly, just be more sensitive and respectful. All right, let's go ahead and take a break. We'll come back. I'll transfer your grades for assignment 1. If you didn't get the complete grade, just do the assignment I attached, and then I'll give you the points. And then if you can't open up assignment 2, I'll just put it in the comments as well. One or two?
Two, but it skipped over. I don't know what I pushed, but it skipped over question 2, and I marked it, and I can't go back.
Okay, I'll just do it from the file. Yeah, I'll send the file.
It'll reopen. So I
No, it
answered
won't
the first
reopen.
question, but then the second question, I think I was saying it like submit or something. It's just whatever. I have to go on to question 2.
Oh, just attach it. I'll just attach it in the file. assignment comments for assignment 2. Just answer it on the Word document. Drop it off. Okay, assignment 2.